briefly summarize my situation and as a patient and what sort of I went through and sort of the process. And then I'll sort of redirect these two smart guys to inform you of the real facts, and we'll circle back. And Dr. Fraley is my regular doctor, and Dr. Kyle Swanson did my hip surgery. So we'll be able to provide some additional details. So how did this start? I had hip replacement surgery, and the correct name I think is total hip replacement, correct?
Correct.
Not partial. Total hip replacement in October 2014. So I'm about 18 months away from that, and the result has been better than I could have ever expected. There is no problem, no complications. I'm walking, doing regular things, walking about 3 miles a day, golfing, regular things. The way it started, I guess I can go back to about, I think it was probably about 4 years when I noticed I started having some pain, and it wasn't really pain that was specifically on the hip. I mean, some of it was on the hip, and some of it was on the leg, and some of it was on the back. So, but it was more than usual. I mean, I think after you hit 50, and I'm 55 years old now, you think, well, it's just old guy stuff. You're getting sore. You're trying to do too many things that old guys shouldn't do. One of which was playing rec league softball, which was probably not advisable, especially when you're playing with people that are 25 years younger than you, and there is beer involved. So I was getting sore, I was getting knocked around a little bit, but it was enough of a nagging pain that I wanted to talk to Dr. Fraley about what it might be. And that was, I think, sort of the first puzzle. And I'm just going to kind of recircle back to Dr. Fraley if he can sort of remember this early pain and what the advice was. Because I think I went in, we talked about the pain and we talked about some options, and we didn't really think, one of the first things that troubled me a little bit was I would be walking and then my knee would buckle. So I thought, well, you know, that sounds like kind of a knee problem. You don't want to have your knee buckle when you're walking around town. You'd be falling down and getting hurt. So I thought it was serious enough to bring it up to Dr. Fraley. And so we talked about this. And I think one of the first things, if you remember this, Dr. Fraley, was, and what I appreciate about Dr. Fraley is he is pretty good about asking questions of the patient, like, you know, getting very specific information and then, you know, suggesting alternatives. But what is the usual process, Dr. Fraley, once you hear someone has pain in their back, could be hip, could be knee?
We look at a few things. First is history. When did it start? What kind of activity bothers it? What makes it better? What makes it worse? What's your family history like? Because in my wife's family, every one of her siblings has had their hips replaced. So if I get a guy coming in with low back or hip pain in that family, I know what I'm going to look for first. You also look for a history of prior injuries or trauma, and anything that's happened recently that may be affecting it. In Joe's case, he had a myriad of symptoms, but they all seem to kind of be lower back or into the hip. And a little bit more history made it look like we were feeling some weakness or enough discomfort with certain motions of walking or running that he get that sensation that the knee was going to buckle, but on exam couldn't find anything wrong with the knee. So we started kind of conservatively working around the hip.
We had knee x-rays and they looked good. And I think we came back and said, well, those look good, so what's the possibilities here? And I think at that point we kind of talked about physical therapy.
Yeah, we did.
And what is your thought on that when you recommend physical therapy?
If we have somebody that doesn't look like they're an obvious person to go to the operating room to replace a joint, they don't have a torn cartilage or tendon, ligament, an injury that you need to put back together, we've had incredible luck with physical therapy and getting people back to being active, full range of motion in the joint that you're having trouble with, and returning their strength. And you want to keep people moving.
Well, and I think one of the piece I remember about that is I did go to physical therapy, and I believe I saw an OFC doctor, and they look at you again and kind of confirm, okay, this is a good idea. So they prescribed a series of exercises for myself for the hip, I believe for a series of muscles all around. It was back, it was hip, it was leg, and I was very satisfied with the instruction on that, and did try it. I know it is sort of demanding. You have to do it every day, right? Or pretty much every day for it to be successful. And so I was pretty diligent and did it. And I actually started feeling better. So, and the pain was going away, and I think is the strategy, and maybe Dr. Swanson, you can jump in here with physical therapy. Does this just strengthen the muscles around what is getting to be to support your bones because you're getting older and the muscles are getting flabby? Is that it? I mean, or
that, and also it improves range of motion for some people, and that alone can move normal joint fluid throughout the joint and has a natural pain relieving effect for people.
yeah, and I thought the pain was better. I think when I decided I needed something to do something, I was maybe taking a leave once a day probably. And I'm a person who doesn't really like to overuse medicine or medical procedures. I always like to ask my doctors, what is the thing we can do? I mean, I had some cholesterol issues, and so I tried to do exercise and diet first. So I tried to go on these steps. But I think after a while, and I was pretty good with the physical therapy, and we met maybe the next year or 6 months, and I said, I feel better, but every once in a while, I would still get this pain, and it would be even like when I'm sitting driving my car. And I was saying, well, this can't be. I need to get a new car and get some softer car seats or something, and then I would be sitting, for example, on a bar stool, and I would have, and that's when it really gets serious. You don't want to not be able to sit on a bar stool, okay? So I went back to Dr. Fraley and I said, this still isn't that great. And I went also to, I was talking with my wife, and my wife has back problems and these sort of things, and I thought, well, maybe it's still related to the back, so we'll check out a chiropractor. And my wife knew somebody, so I went to the chiropractor for a while, and when you go to a chiropractor, you pretty much, your back and everything feels better because they have those rollers, right? And you can go in that room and you can fall asleep, and so almost everything feels better. So I did that for, I don't know, maybe 6 months, but it was still pretty painful. And like I say, things kept coming up, and it didn't seem to be going away, and I would wake up and have to get the heating pad on my back right away. So I was just looking for something. I was kind of a fairly young person here yet, so I really wanted to figure out if there's something else we can do. And I think then, Dr. Fraley, we maybe came back and decided, hey, we've been trying a lot of things, what's next?
So at that point, took a look at the back, took a look at the hip, did some range of motion in the clinic, got some significant discomfort with that, and time for an x-ray of the hip, and it showed some pretty significant, we call it degenerative disease, you'd call it arthritis.
And that was interesting because I think initially you thought, arthritis, and I didn't think of it as arthritis, but that's essentially what it is, correct, Dr. Swanson? And so you were the first one to look at my hip, and it looks like do we have Exhibit A over here?
We have Exhibit A for sure. I was just sitting here thinking what an enjoyable story, and that I'm glad. It's really nice to hear how well Joe is doing, and that I'll continue to do these with him, but you'll also know if things aren't working out as well with him that I might not be here next time. It's a great story to hear. Total hip replacement is my favorite topic to talk about. I'm very passionate about it. It's a very hot topic in medicine. It's one of the highest quality of life improving operations of any that exist. There's over 500,000 hip replacements done in the United States annually. There's a lot of internet information, there's a lot of public media information about it, there's a lot of advertising information about it. It's a very interesting, progressive operation that even in my career has changed significantly for the better. This is an average Joe's hip. This is we call this a pelvis x-ray. And we hang x-rays like you would be shaking hands. So the right hip is to your left, and the left hip is to your right. And if you look at the patient's right hip, you see a spherical ball with a socket, and there's space that exists between that socket bone and the ball. That space is occupied by cartilage, our body's natural tread, like rubber on a tire. The progressive loss of that space, or the loss of cartilage, is osteoarthritis, what we're all developing through time. The left hip is that average Joe's bad hip. And you can see the glaring difference. A flattened, amorphous type looking head, that joint space has dissipated to nothing, to the term often used bone on bone. Cysts that have formed in the head, the increased kind of whiteness, we call that sclerosis. That's from those bone surfaces that effectively are moving against each other, or raw bone on raw bone. That's what really produces pain from a bad hip. 90% of that time that's in the groin, to a lesser degree in the buttock. It rarely radiates down the leg, but never below the level of the knee. This is an easy diagnosis to make and tell him about his severity based upon the x-ray. So I had a pretty good idea I was going to be seeing this guy for a little bit.
Well, on a scale of 0 to 10, 10 being the worst, would this be like an 11?
Oh, 12.
So it wasn't that difficult for me to make the decision on this. And incidentally, this is like an exclusive x-ray. Nobody's ever seen this, so I don't think my wife has ever seen this, so just so you know. So a lot of people, I talked to, spend a lot of time thinking about the hip decision, and everyone should do what's comfortable and right to them, but it just made a lot of sense to me that this pain was directly related to this, and there was even times, like I mentioned joking about the bar stool, but I would start to get down from the bar stool and it would feel like I'd gotten a cramp or something right in my hip, and so a lot of it was, fairly serious stuff for me. And Dr. Fraley, you mentioned family history and trauma about things you did, and I think we did eventually talk about one of my uncles having a hip replaced when he was a really young person as well, in his 50s. And I also was a hockey goalie in high school. So we were putting a lot of pressure on our hips. I was not putting as much weight on the hip as I do now, of course, but I think that may have impacted a lot of this as well, from what I understand.
For sure, hip problems can run in families. We tend to think of them as multifactorial in reasons. Use and abuse, again, genetics affect wear, prior trauma, age, weight, all these things affect how our hip wears over time.
And part of the decision is, when you tell people that you're going to get your hip replaced and you're, 52 or 53 years old, and they kind of give you this look like, shouldn't you be 80, or, what's wrong with you, why aren't your hips lasting longer than most of us? And it was sort of an interesting experience and reaction to get, because it almost felt like discrimination or bias against, young people who need hips replaced. But as I came to understand, it's more and more common. What do you all know about that?
The big thing about it isn't so much the age. We used to look at that 20, 30 years ago because we know you're going to wear out an artificial joint. What we look at now is quality of life. And hey, if you can't sit on your bar stool, we got to do something.
that was it. I mean, we really gotta think about the future here. And the surgery went very well for me. I I was heavily sedated, so I may miss some of the facts on this part of it. But it seemed like it was an hour?
About an hour.
Okay. And my wife just said, you said everything went well, came out into the room and gave a thumbs up. Are people, I imagine there are different people, different sizes, have different dilemmas with surgery. Can you talk about that a little bit?
Sure. In today's hip replacement, there are some different techniques that can be utilized for the insertion or the way in which it's done. Pretty much anybody who's doing this on a regular basis are using techniques today called minimally invasive techniques or muscle splitting type approaches, not muscle cutting. It's made the surgery easier, it's made the recovery easier and faster. It's been one of the big improvement areas in total hip replacement. If you look at this x-ray, you can kind of see the bright white is the metal parts of the hip, or the artificial parts of the hip. And, total hip replacement involves the removal of the ball and a reshaping of the socket and a placement of a pin inside the femur. The socket part and the pin part are made out of titanium. The ball is either made out of a metal alloy or, even more commonly today, ceramic. So that is a ceramic hip replacement. Each piece is custom sized, including the socket, the ball, and the pin. And quite different in everybody. Everybody has a different shape to the bones and the socket. And the number of parts or inventory that it takes for a hip replacement is a lot, just because of the different size and variability in size that exists for people. We do most of these surgeries for people under spinal anesthesia, another piece of the pie that's really made the recovery easier. There's less risk and less complications associated with spinal anesthesia than when you think of a general anesthetic, or putting a breathing tube in. We allow people to put full weight on this right away. In most cases, get them up the same day and to start walking.
That's fascinating about I wasn't aware of the different sizes, so once you get in there, you have to figure out what glove size I need.
Exactly.
Okay. That's very fascinating. And I think I had the spinal anesthesia, which I didn't ever feel anything, and then once they get you back in your hospital bed, they're very diligent about getting you the appropriate amount of pain pills every 4 hours, and I willingly took those. And it went very well, and I was up the first day. They did have me stand up, and I was kind of amazed at how well it worked at first, and I was walking around the hospital very soon. I think I got released. I went in on a Tuesday, and I think I left Thursday morning. So I think I did spend 2 nights in the hospital, but I think that's a little bit, maybe half a day ahead of normal. And they gave us training on the exercises you need to do to work it in, but as I understand it, it's much easier rehab than a knee because your rehab is walking, basically, and that's what I did. Am I on target there? Have I said it?
That is correct. General motion is not a problem after hip replacement. It's an operation that seemingly is just a little less painful area than around the knee, less swelling. It's overall faster in recovery. Most people that had a hip and had a knee replacement, they'll take the hip. It's generally a little easier. There are a few exceptions to that.
Right. And so after that, as I say, 18 months, and I have been, walking, and I'm not a super exercise freak, nut, so I should be, but and I golf and
Dance.
I dance, yes. I knew somebody was going to bring that up. I don't know if any of you have heard about this, but I was asked to be in Dancing with the Stars, Mankato Dancing with the Stars. It's a fundraiser for the Red Cross, and what they do is they pair up average Joes, average people, with professional dancers, and we go through a 6-week intensive learn how to dance, and it has to be even more intensive with me because I'm a very slow learner. So I did a hip hop routine And I actually, so this is kind of my joke, I went from hip replacement to hip hop and became a poster child for the hip replacement department at Orthopaedic and Fracture Clinic. And
Thank you for that.
I don't know if they've got my publicity photo up in their offices, but you do, okay. And I think we're going to take some questions as well here, just because I think that can be more interesting. But I will say the dancing, which is actually tougher on my cardio than it was on, if you know anything about hip hop. It was a 1.5-minute dance, and I think it was like running a marathon for me. But it's actually was quite a bit of driving on that hip, and I did consult with Dr. Swanson before I did this to make sure all the parts were going to be good. Like, the porcelain thing about the ball, it kind of sounds like porcelain could break, you just don't think of it like hip hop and porcelain, right? But he assured me it was way better than the average toilet. And the titanium is taken from the same stuff they use with the space shuttle, the nose of the space shuttle. Do I have that right?
That's the ingrowth surface. That's right. That's the stuff that the bone goes into, correct.
So everything looks good so far. I thought that Dancing with the Stars, I was hoping, I publicized the hip thing a little bit, thinking people would see it like wanting to go to a NASCAR race. You go to see if the cars bounce off the walls and go up into flames, so they're waiting for the guy with the fake hip to see if he crashed and burned. But it's all good for me, and I appreciate these two gentlemen helping me with this health issue. It was just like I say, an average person who wants to feel better, and I do. So I guess we'll take questions?
In the back? In the back?
What determines that one hip goes and not the other? I mean, why one but not the other?
Nobody knows the answer to that question. But about 50% of the time, in time, the other hip will also progress towards advanced degenerative disease.
Is there anything the patient can do to prevent that?
No.
I drink more milk.
Not a calcium problem. Yes?
I've had both hips replaced within 4 years, so that answers your question. I think it's more genetic.
Probably the largest component of the multifactorial reasons, yes.
And I had mine started at age 50, and I had it in 54, which I don't know if you remember, but you did that.
Do you have anything more you'd like to say? Stand up, come on up.
Dance a little so we know how you're doing.
There's our next Dances with the Stars right now. Yes.
Sports, running, basketball after hip replacement.
The question is about activity following hip replacement.
Pretty aggressive activity.
I think especially since about 2002, the durability and the wear properties of these bearing surfaces are off the charts. They're about 1,000 times more wear resistant than that which existed prior to that. Although there are stories, and I have some of patients about high impact sports like running or basketball, jumping effectively, it makes me nervous. I think theoretically there's still some trade-offs with a mechanical device that just makes good common sense. I'd like to see these devices last in our world today 30 plus years, longer than they've ever seen before, and I think the technology here exists. But they don't have any give properties like our normal joints, where cartilage actually has some cushion effect or give properties. These are hard-on-hard bearing surfaces. People do those things, but I try to kind of steer them away from high-impact exercise. It was well ingrained in me what Bo Jackson tried to do, and it wasn't a very successful outcome. But there are different theories about that, but I think most people feel as I do about that.
How about running in your mid-50s when you're not having symptoms at present? How much likelihood is that going to cause problems down the road?
The question is, does running wear your hip out? There's no literature suggests that. We see people that run well in their second half of life. It doesn't effectively wear your hip prematurely. That's how we know there's clearly more to it than that. However, high impact running is the hardest to recover from our joints. It's not that we can't run at age 40, it just takes longer to recover. And so a lot of people, especially in the second half of life, move more towards kind of lower impact exercises that are sustainable on a daily basis.
Timing, as an arthritic hip becomes worse and the joint deteriorates, is there a point in that progression that is the best slot of opportunity to have the hip replacement surgery? In other words, how bad do you let it get?
The question is, if everybody here is how bad do you let it go and what is the right time to have a hip replacement? I think Dr. Fraley said the correct phrase. It's a quality of life operation. You can't effectively make the hip so it can't be replaced, in my mind. However, I see some people that put it off and effectively create more problems by getting really out of shape. And then you're dealing with not one problem, but two. Or begin to do things that have a deleterious effect on their body, like taking an inordinate amount of anti-inflammatory medication that raise your blood pressure and burn a hole in your stomach. So I think when it becomes affecting your normal quality of life within reason of the things that you want to do, again within reason, that's the right time.
The other thing that affects that, if you're having problems with that one joint, you're going to change the way that you walk, and we call that your gait. When you do that, you do put more stress on other joints. You want to keep everything moving. If you don't, you do get out of shape, and the more out of shape you are, the harder it is to rehab afterwards.
I agree with that very much. I see a lot of people that have hip and back pains. I tell people don't have your hip fixed to solve your back problem, but effectively when people walk more normal, walk better, it helps other joints a lot, especially back pain. And it's tough to not exacerbate other problems, as Dr. Fraley said, by walking with a limp all the time.
Joel, when you were having the pain initially before the surgery, did you have the pain all the time, even when you were trying to rest and sleep? And when you were off the feet, did you still have the pain?
The question is, how often did I have pain? And in the beginning, it was on and off, really, and that's why I kind of didn't like rush into it. And as it progressed, it got worse. And like I say, I think, I mean, I didn't really have trouble sleeping. So I think when I was off my feet, for the most part, it wasn't, you know, super painful. But when I was walking, it was painful, and I was limping. I tried not to limp, and I couldn't, you know, people would look at me like, why are you limping? You know, I don't know. So I think there was a mix, but when it started getting worse, I just thought that's the signal right to your brain that you got to do something.
Yes?
I've heard about partial hip replacements or hip resurfacing and stuff like that. What determines which way to go there?
Hip resurfacing was very popular about 7 years ago. It was popularized by a guy in England, and it was advertised heavily. They were a metal-on-metal bearing surface. Metal-on-metal bearing surfaces have not fared as well in the United States, whether total hip or resurfacing hip, as the data in England would suggest. While I did do hip resurfacing, it's really fallen significantly out of favor and compared head-to-head with total hip replacement in the bearing surfaces today. Partial hip replacements are rarely used except in cases of fracture, broken hips. Does that answer your question?
Yes.
There was one related to that I just wanted to follow up on. So are there treatments? I've heard about treatments like cortisone treatments and that sort of thing. Was before it's really bad that can help, or?
Correct. In addition to some of the things that I mentioned, specifically physical therapy and the use of anti-inflammatories or medicines like ibuprofen, with people with mild to moderate osteoarthritis without complete loss of their joint space, sometimes an injection in the hip, cortisone, can give some temporary but often unpredictable results. To have that though, it has to be done with x-ray to ensure that the needle is placed in the joint. So, but that is an option for some. Yes?
Or the parts for the replacement surgery attached to the bone. Especially I'm thinking of like the pin going into the femur.
Sure. How are the parts attached or affixed to the bone? The parts themselves, the socket and the pin are made of titanium, but they have a special grit coating. We left some parts up here. I encourage you to feel these parts and look at them. It'll make sense when we're done. They have a special grit coating on them. It's our job to create the shaping of the inside of the bone and the fit. It creates a macro fit. It's tight when it goes in so it can bear full weight. Over a period of about 6 to 8 weeks, the bone actually grows in the pores of that sandpaper field. They're microscopic pores, about 400 microns. And that's what creates a biological lock or ingrowth, we say, to the parts. That's what holds them in. Your muscles actually hold the hip joint in the socket.
So it's good to keep the muscles strong.
Correct.
Other questions? Oh.
Looking at the x-ray there, and if it was arthritis and stuff, it looks like the femur bone is deteriorated more than the other side. So, like if you have arthritis there, in the socket, is the femur likely to be deteriorated itself too, or not so?
To some degree, and in some people, especially in long-standing cases, you can get what's called disuse osteopenia, or atrophy. If we don't use our bones, or bear weight in a symmetrical fashion, one bone will get thicker, and the other one effectively will get a bit thinner. So in long-standing cases, you can see that, but that can easily be overcome with hip replacement techniques today.
And what's the recovery time?
Question is, what is the recovery time from hip replacement? It's a little bit different for everybody, but the recovery, if I tell people, the more you get up and get going and walk, the faster you'll get over hip replacement. In general, most people are getting back to doing the vast majority of things by about 6 weeks. But over that, incrementally each week, they're doing more, walking farther, walking longer. So it's a very progressive type of rehab. I tell people, plan on giving me 6 weeks of your time.
There's no pain involved.
Excuse me?
There's no pain in the recovery period?
There's pain in the recovery period. Yeah, I think it's very, I'll have our patient talk about that, but go ahead, Joe.
Well, for me, it went really well, and like I say, they give you the hardcore painkillers for. I think they gave me 3 or 4 weeks of them, but I only took them for 2 days, and then the Aleve was fine. Yeah, there was pain in the swelling was there for probably 3 weeks or so as I walked. I did my walking during the day, and then 2 times a day, I think, and then you come and rest and put the ice pack on the swelling, let it go down. But I had the surgery, I think, October 21st, and I think I was back at work the day after the election. So November 8th is when I was back at work, probably. So it was about 3 weeks, and I was still, I think I went for 1 walk with my walker, and I went for a couple, maybe a week with the cane. Yeah, and my neighbors were looking at me like, why are you carrying your cane? But yeah, I mean, it went very well for me, and like I say, I think after 6, and there were some things you're not supposed to do, right? Turn the right way, but like after a year, you can hip hop dance, right? That's okay.
Even sooner.
So that went very well.
What's the lifespan now of the newer hip materials?
Since about 2002, the bearing surfaces again have really far exceeded what existed before that. We have 15-year data on this hip, exactly what Joe has, and we still can't measure wear at all. And so that's far better than anything we've ever seen. We have simulation data, basically data that's done in a lab that simulates the number of cycles that would occur over a 30-year period, and still negligible wear. So I think to myself, if we have biological fixation, the bone grows into the parts and the bearing surfaces don't wear out, we have something that can conceivably last a lifetime almost regardless of age. But that remains to be determined. People are living longer, and we have pushed the age span for total hip replacement. Mine spans 16 to 101. And so we need longer and better parts, and we've definitely made some pretty big leaps in the hip world.
Striker hips.
Yes,
Do you use them anymore?
a lot. He's asking a question that pertains to product recall. It's a good question, because there's a lot of information advertised, especially by the legal world, about it. There are 3 or 4 major manufacturing companies of hip components: Zimmer, Stryker, Biomet, Johnson & Johnson. They are the big ones. Over time, all companies have seen of some specific line of a product a potential or a problem. And in all companies, the problem that really was unbeknownst or unrealized was a problem of metal on metal ions. That became Stryker's problem, DePuy's problem, which actually Stryker's problem involved 20,000 hips, DePuy's problem involved 100,000 hips, and Zimmer is yet to be determined. But it was all something that really will rewrite history about what's been discovered by it. Of course, it's known about now, it's not utilized today, but they're still the #1 manufacturer. Stryker specifically is still the #1 hip manufacturer in the world in its utilization. So there's a specific product line of each of these companies, a specific type of hip that had a mechanical problem. Love this guy.
No, you're not this thing.
Uh-oh.
I'm going to save a doctor visit here. I got 2 hips, obviously they're replaced. One is fine when they sit on an ice rink. The other one I get out of an ice rink, it hurts. Now, obviously they're done by 2 different people, 2 different times. Is that something that I should get re-examined to why the coldness? It appears to be the coldness, because I sat out a baseball game yesterday, and after an hour, it started hurting big time till I get it warmed up. So I don't know if it's part of the material I guess I'm just trying to figure out what advice you would give me here.
I'd be happy to look at it. Oftentimes, however, sitting puts the most tension on the sciatic nerve. Most people, over 9 out of 10, pain with sitting especially, is irritation of that nerve or a problem called sciatica. It's not a hip problem at all. But one can discern that very easily by some plain x-rays and an examination.
The noise seems to happen when it's cold.
Hip stays the same inside your body 98.7 year-round, no matter what outside temperature is. It's the same temperature as your core.
Have you ever had a problem with the titanium growing to the bone?
That's called the ingrowth rate, or the rate in which these parts of the bone grows in. It's about 99.2%. It's actually pretty rare. But we really favor trying to use unccemented parts without glue, as often as we can. You can get 100% fixation if you glue the parts in. That's a little bit old technology, and we try to steer away from that. If you glue something in, just like if you cement a pole in the ground, you cycle it enough times, you will eventually debond it or work it loose, like a windshield wiper. So everything that I consider cemented has a finite lifetime. So I'm always trying to achieve biological fixation, but that brings that low risk that the bone won't grow into the parts. It's pretty rare, actually.
Any issues with people with metal allergies, like nickel?
Many people say they have a nickel allergy, especially I'm allergic to cheap jewelry. I've heard that many times. That's called a delayed type hypersensitivity reaction. If I wear a cheap necklace, it can cause a bit of a rash. That actually does not occur in the body. There's a very low rate of nickel. It's been well studied, and there aren't any cases of documented true rejection of these inert parts.
The growth of the bone is different for older people, younger people. He's young here. I'm older. What happened if I have to have surgery like that?
Your bone will still grow. No problem. No problem. Sometimes more than anything else, it's in some medications can inhibit some bone growth. But no, age doesn't, yes, there is a difference in our bone growth as we age, but these parts are very bone loving, I say. And in most cases, over 99% will get the bone growing parts.
Is there anything you can do to exercise or strengthen your muscles before surgery?
Is there anything that can be done to strengthen one's muscles before surgery? It's a great question. It's, I wish I could get everybody to kind of get in the best shape possible before surgery, because people like Joe that come into the party in good shape have a much easier time recovering. No question about that. Pain can limit one's ability to exercise and do things. I try to encourage people to try to get in the water. It offloads our joints, it lets us move our joints, it lets us burn calories easier than trying to walk with a bad hip a mile. But yes, the more one can exercise and get themselves in top shape, lessens one's risk for surgery and makes the recovery, almost regardless of what orthopedic procedure you have, easier.
Well, looks like we're at the end of questions. Are we at the end of our time pretty much? Okay. It's been great. Thanks for coming. A lot of great questions, and I think everybody learned something. So thank you.